excited to have our group here today. Chaplains do a lot of work in the community and in hospitals, and we as a group wondered, how did the chaplains cope and what did they do during the pandemic? And not just the pandemic, what the heck do they do every day to help others? So the goals for their day today is to describe how chaplains support patients, families, and friends in times of crisis, support members of the healthcare team in times of crisis, and how they practice self-care and maintain resilience in the midst of crisis, and especially continuous crisis that we've been going through for these past couple of years. Who we have with us today is Reverend Tom Adel, and I apologize in advance for butchering names. It's one of my talents. He's a UCC minister, art therapist, and director of spiritual care at Reading Hospital, which is a 12-chaplain department that provides spiritual care to patients, families, and staff of all spiritual backgrounds, including non-religious orientation 24/7. Susan Iliff is a board-certified chaplain at Reading Hospital, specializing in palliative care and maternal fetal health, and is a certified clinical pastoral education supervisor candidate. Reverend Dave Troxler is a chaplain at Reading Hospital, serving mainly in the intensive care units, emergency department, and trauma program. For today, most definitely keep your mics muted, and if you don't want to be on camera, turn off your video. Depending on how things flow, we might just allow some live questions, but otherwise, as usual, put your questions, comments, and anything else in the chat. Thank you so much.
Good morning. Thank you for the invitation from Circle of Life to talk about our work. It's an honor and privilege both to be a chaplain and to present to the community the work that we do at Reading Hospital. Again, I am Tom Adel. I did well on the name, and I'm the director of the Department of Spiritual Care at Reading Hospital. The work that I do as an administrator is to equip our chaplains in the work that they have in the hospital to meet the needs of our patients, their families, our visitors and guests, and our staff. I was relatively new at the position at the onset of the pandemic. So in a way, that was an advantage for me because working during a pandemic was in a way normal as a chaplain for me because I didn't have something to compare that to. I did understand the psychological factor, having been an art therapist for the previous 25 years at Reading Hospital, so and an administrator. So I felt like I was in a good position to do the work of my job. However, it was for all of us new territory, and there were a lot of unknowns for us to face individually and as a department. So as the pandemic unfolded, we had to ask some fundamental questions about our work, what it meant to be exposed to the virus, how to serve our patients, and how to continue to exist and to meet the needs when we were at risk of having chaplains become infected. So as the administrator, we ended up dividing our team into two groups so that if one team was infected by any one of the members, and again, we didn't know what would happen if people got COVID in our department. It was a big unknown, and it was a scary thing in some ways, but we knew we had to continue to work no matter what. So we divided our group into two so that if one team went down, the other team could still be there to continue our work. And our work did, we determined very soon after the pandemic began, our work did continue on the floors. So we were different than some other hospitals who had chaplains, but did not go out onto the floors to visit patients and to be in the rooms and to be on the floors with the staff. We continued to do that throughout the pandemic. So one of the tasks that the chaplains typically do became more accentuated as we were out there on the units with the staff, and that was taking care of the staff. What happened at the beginning of the pandemic, of course, was that visitation ended, and the chaplains will tell you a lot more about that and what that was like. But that meant that the staff was taking on the role of not only caregiver and professional and medical provider, but also a family role. And this was very challenging for the staff. And so while the chaplains have always had the role of supporting staff as a part of the work that they do, it became much more important and central to the work of the chaplains to look after our staff. So as the pandemic unfolded, we adapted to the circumstances. One of the really challenging things as a director was to see some of our chaplains become infected. And we assumed at the time that it was because of their exposure to the patients, but we continued to visit patients regardless. What we found out later was that probably the infection was due to community spread and could happen anywhere, and not necessarily just because these folks were in patient rooms. But as an administrator, that weighed heavily on my heart. And you know, the work of a chaplain isn't an easy road some of the times. It's certainly a calling, and people go into chaplaincy because they feel equipped, but that doesn't make it easy. And in addition to the typical stress that people felt doing this vigorous work, they were doing this in the context of an unfolding pandemic. So there were a lot of stressors happening, coming at people from many different angles. Resilience was certainly an important component of what was needed to do the work, but what we found through our research was that even people with strong resilience could become overcome by the stress of working in a hospital during COVID. And as I prepared my thoughts for today's discussion about this, it occurred to me that we really haven't had an opportunity to process what that stress toll took on us as individuals. I think that this is probably a common theme throughout healthcare, that people are still continuing to carry a burden that has not flushed out of our system yet. And so while we're still going to work every day, telling our story is a new thing, it's an important thing, but it's still at the early stage of where we are.
Okay, sure. I'm Dave Troxler, and thanks, Tom. Ministering to staff has been a big part of the work we've done as chaplains. And I just want to share two brief stories. One dealing with a nurse who, because of early precautions of COVID, you know, you go home, you're afraid to bring the disease home. And this young woman, or the nurse, I haven't hugged my kids for, I don't know how many weeks it was. I haven't had a hug from anybody, and the conversation began with me coming to the floor to deal with the needs of a family who just lost a loved one to COVID. And the conversation with this nurse began with, I've taken 5 bodies to the morgue already today, and I haven't been able to hug someone in weeks. And there was obviously precautions. It was supposed to be 6 feet distancing, masking, and this woman just needed a hug. And I was able to just embrace her, wearing the full PPE gowns, which I'll talk about that in a minute. Another brief story is early on in the pandemic, the need to minister to staff did not just entail ministering to nurses and doctors and those who were doing direct care. I was called to help the hospital operators who do not have patient care, do not even in rooms or departments that deal with patient care, but they were getting inundated with calls from the community. How do we deal with this? Where do we get PPE, the personal protective equipment? How do we stay safe? And the hospital operators are being asked to field questions from the community they weren't accustomed to getting. And so my support was actually to going into the hospital operator's room, which is a closed room off the lobby of the hospital, and just ministering to them. It took us in different places because COVID affected everyone in the hospital at whatever position they were in. No matter if they had patient care or not, there was something that they were responsible for that they had to respond to. The one last thing I want to talk about, and so let Sue talk about some things here. We had to go overnight from this kind of conversation to conversation that required us to wear all kinds of other devices. We would have to wear N95 masks. We'd be wearing hospital gowns. You don't mind me turning this up a little bit. If you're coming in to minister to a patient and they're seeing you wear this kind of equipment, they're not really thrilled about that. They're thinking the worst. We often have the double mask over the one. And we had to do that to preserve the N95 mask beneath it because we were supposed to keep those things until they fell apart. And we would have to do this for each and every patient we saw. Different gown, different gloves, different mask, and a face shield. This did not engender real positive contact.
And we're having trouble hearing you.
And that, of course, is part of the problem. The communication and chaplains are accustomed to having a hands-on kind of ministry where you're actually able to deal with patients face to face and in person. I'm taking soft with the wrong word. You're supposed to take the gloves off first and the yellow gown and then do the hand washing. But if you're coming into a room dressed like that, and all the people you see during the day are all dressed similarly, there's a reason for the patient to feel worried. And we're having to address not only their physical and spiritual and emotional needs, but we're having to deal with what is fearful, and making that part of our ministry to help them recognize that they're still being cared for, and having a sense that they're important to us. And even though there's a distance that is forced on us by this apparel, that they're worth. And that was hard on the staff too, because nursing staff was not accustomed to doing that in all circumstances. And that's how we went into practically every patient room. It was very difficult for patients. It's difficult for staff. There's a number of staff people, not just in our organization, but many organizations that pandemic burned them out. And I could say I lost some good friends to the pandemic because they just couldn't handle all this and trying to do their job. sadly, we lost a friend to the disease itself, but anyways, this was the kind of approach you had to do with every patient. And like I said, the one nurse I talked to, we were wearing gowns similar to this, and go ahead and hug your family in how many weeks, and I just had to give her a hug. Well, the rest like this, I couldn't tell who the nurse was because of all the masking. I just heard her heart, and it was breaking for the patient she was caring for, and for the family that she was worried about, that I'm going to take this disease home after caring for so many COVID patients.
A couple of things that Tom alluded to, and then also Dave, I'm going to kind of circle back to. And one of the things was the suddenness of the change, that in the midst of this emerging pandemic, the key word was there was a lot unknown about it. So that just in itself engenders fear. But the policy of visitation at Reading Hospital changed overnight. One of the things as far as our department, we weren't furloughed. We were there throughout the whole pandemic. Initially, because of the lack of PPE, we chaplains were not allowed to go into COVID positive rooms and see those patients, strictly because there wasn't enough PPE and the medical care was more important than the spiritual care. That makes sense. But as soon as there was enough PPE available, we were there on the front line, doing our best to provide support to the patients. One of the things that was really challenging, and I just remember the halls in the hospital, because they were so quiet, because there were no visitors, and there was staff moving around the hospital, but that was a huge change. So just the whole sense of that hospital had changed just like that overnight. One of the things that I remember was dealing with families over the phone, because we would try to support families, and their anger at not being able to come in and visit their loved one when people were critically ill, whether it was with COVID or something else, not being able to be in there with their loved one. I remember a lot of instances, and I think the lion's share of this fell on the nursing staff and the personal care aides as well, to be in a room with an ill patient with either an iPad or a smartphone where there was video and audio capability, and positioning it so that the family, wherever they were, and it could have been a large group of people connected, could see the patient, obviously see how ill they were, and if the patient was able to communicate, to be able to talk and interact with them. So we ended up doing that, and some of those were heartbreaking. I won't say conversations, because I wasn't necessarily part of the conversations, but I was there supporting it happening. But just to have to do that at a distance was so hard on people. And I particularly remember just that, the pain of that, and people not being able to be present in person, but also people's anger about it. And other than kind of listening to it and saying we can't, there were very, very few exceptions made for someone who maybe needed somebody as a primary support if they were developmentally disabled or something, but very, very rare exceptions. So it was a huge change. I remember also the fear of the staff, whether they were clinical staff on the front line or just as the operators, if they were dietary support, delivering meals, whatever their role, people were afraid of taking whatever was in the hospital, in the rooms, taking it home to their family. I don't live with family, so I didn't have that same fear, yet I was certainly cognizant of what am I doing with these street clothes that have been around the hospital, underneath a gown or whatever, when we were going into COVID positive patients' rooms, and what that was like to take things off put them in the laundry room, whatever the particulars. I also remember the importance of humor and listening to some staff members talking about going home and stripping down, taking off their work clothes in the entryway, in the garage, on their back porch, and then laughing about their neighbors seeing them and wondering what's going on. But that was a reality for people, that was driven by fear. That did lessen over time as we learned, the collective, we learned more about the virus and how it was spreading and whatever, but it was powerful, particularly in the beginning. I had one more thought and it's sort of escaped me. Oh, I know, one other thing that I found really difficult for our own group, when we split into the two teams that Tom alluded to, that made a lot of sense, but it was challenging because we were trying to cover, we have chaplain coverage 24/7 at Reading Hospital. And so we had to continue that, and it just shifted when people were going to be present and whether they were on first, second, or third shift. We also lost some team members that chose to leave the department for various reasons at that time. And when we did have people who were ill, whether it was COVID or otherwise, I remember being really stretched, really drained, overextended. And that was a challenge because we provide 24/7 care. And we did do it, but I think it was challenging. It took its toll in a way. And we certainly were not the only group of staff at the hospital that was happening to, because the staff shortages did start early for various reasons and have continued. And I'm grateful that we're at much a higher number of chaplains in the department now and able to do better self-care in part because of that. But that was just another thought that was challenging.
I'll go back to Dave and then follow up with Sue, just my reflections on some of the things that I heard them say. That N95 mask that we wear under the surgical mask is not comfortable in any form, way, or fashion. And while the chaplains went in and out of rooms, which meant, they take their masks off periodically, there were staff who wore that for 12 hours straight through. And, they ended up with skin issues that they just soldiered through, along with all the other demands that wearing masks brought, as Dave talked about. I also, in addition to remembering the halls being empty, other than staff, remember driving to work and how odd it was that on roads that were typically clogged for rush hour were empty, emptier than they would have been at 2 a.m. Before the pandemic. So there was this sense of, I think, the importance of our mission when you were faced with things like that, seeing how unusual times were for us to be allowed to be out going to work, which I think I don't know about you all, I did recognize was a kind of a double-edged sword. It was kind of helpful to have an ongoing routine to be able to continue to do what you thought you were supposed to do on a daily basis, which helped stabilize sort of what was happening emotionally and mentally during the pandemic, even though at the same time the work itself was quite different than typical. I also, I don't know if Sue talked to the same nurse that I did, but she was talking about changing on her porch with her neighbor watching. And she yelled, "What are you looking at?" to him. That was perhaps the part that stuck out most for me about that story.
The other part of that story is, this nurse was doing this for a number of weeks before one day her husband says, "You know, you can use the back door and come in the basement." And the nurse not realizing what she was doing, and thinking, I got other ways to get into this. We, Sue mentioned about holding the phones or the iPads to families. And this was true not just of COVID patients, but patients who were in the hospital for other reasons. They were under the same restrictions. I remember one trauma patient was a young Amish man. And the Amish community, of course, being a whole different set of parameters of how having to explain to him some of the problems with the COVID. And this is early on in the COVID pandemic, but obviously he was not there for COVID, but he was there for another traumatic injury, and having to explain to him and talk to him about what was going on that he was not versed in. And so a lot of what we're doing was educating people. At the same time, trying to remain, and Sue mentioned our sense of humor, we have that, we try and use that in appropriate ways. Something else we could say, oh, the masks. Tom and I both had full beards when the pandemic started. The PPEs don't work well with facial hair. I've gone back to a goatee because this actually fits over the goatee. Tom, I see us come back from vacation with a full beard here.
But I did shave so I could wear the mask.
But yes, but we the men in our department who had facial hair, we had to take the facial hair basically off. If you didn't do that, you had to wear what's called a PAPR, which is a portable hair resuscitator, which looks like a NASA backpack. And as Sue mentioned, with the personal protective equipment, the PPE equipment being in short supply in the hospital, I couldn't justify taking that away from a medical staff person who needed that in a room. And so continued opting for this, and facial hair went, that was a sacrifice for my wife too. She liked the beard. And we had to have this discussion about doing that. And so we're getting to the point now where we can have facial hair again for those that have that. But that was just one of the, we had to make sacrifices, whether it's the time of our shift changes, just how we adapted to minister to people. And that of course affected how we ministered to one another. I think Tom did a good job of helping the team keep focusing on what's, personal resiliency. And we tried to implement programs in the hospital that would help other staff, whether nursing staff or environmental services staff, but trying to help them with ways of coping. But we also check on each other and how are you doing, and do more than just a cursory hi, how are you today, but really try to listen and give staff the space to be able to take a break. One of the humorous thing that was humorous to me, I don't know if anyone else experienced it, but with the reduction of number of people in the hospital, the cafeteria was often empty. And the hospital has always some music playing over the PA system in the background. And one day I was in the cafeteria, and the song that was playing, this is early in the pandemic, was a song by the group called The Police, "Don't Stand So Close to Me." And I'm just sitting in the cafeteria listening to the song overhead and just thinking how funny it was, with these 6-foot distancing, and that was the song being played. But it was something that you had to find moments where there was something of humor, but also life-giving. Tom is his art therapy directed some of us using our talents and ways of expressing ourselves, whether it's through poetry or writing or Tom's a very good artist. Just some of the things that I've seen him paint, just needing some of those outlets and encouraging other staff to find outlets to that. One of the other things that happened during this pandemic, a number of us in the department were trained for critical incident stress management, which applies to many different circumstances, but helping staff to process their feelings when dealing with emergencies, not just COVID related, but certainly COVID impacted how we care for people in a stressful environment that may be a different type of injury, another type of setting, but affected by COVID.
Something Dave said reminded me of another, what to me was a pretty big change in the support that we provided at the hospital. Dave mentioned that young man, the trauma patient. Our ED was much less busy than it typically is. And we have a chaplain on each shift who is what we call the duty chaplain and is responsible for the majority of the emergencies in the emergency department, whether that's a trauma or just someone who's critically ill, heart attacks, whatever it is. And also when there's just calls coming in from around the hospital. Well, there was less happening down in the emergency department because people were not out and about. Tom mentioned there was less traffic on the streets. There were less accidents, whether it be motor vehicle accidents, motorcycle pedestrians being hit. And just because people were not out and about. But I think another thing that sort of stemmed from that I think was pretty pervasive and contributes to, and I use the word trauma when I think about the societal trauma that we've all experienced in some way or another because of this pandemic, was the isolation. And for me, if I had not been working continuously during the pandemic, I don't know what I'd look like, how that toll would have taken on me, because I do live alone, and the resilience factor is very important. One of the things that I ended up starting doing much more during the pandemic was getting out and hiking, being out in nature, just the beauty of being in God's created world and getting some physical activity in other than walking through the halls of the hospital was very nurturing and healing for me. And I keep that up to this day, but it was just making the time to do that because it was important. But that isolation, whether it was patients in the hospital, families who were stuck at home and not able to get out, and until whether it was Zoom or other modalities of connecting became more in vogue and in use, and people learned about how to use that technology. I think that isolation was a really big part of this pandemic that took its toll to people across the board.
Things that I did during that time, when Tom mentioned about the department being divided in half. I know I was on the Sunday to Wednesday group, and we sort of handed off like midday on Wednesday for the Wednesday to Saturday group. But because I had 3.5 days off in between, I really got involved in flower gardening with my wife, and so I wasn't out and walking in terms like Sue was doing, but finding some just beauty in plants and taking more care of my lawn than I've given for a long time. But just having that as something to invest in life giving, and that's, that was clearly part of that. My mother-in-law died of COVID during this time. Yeah, she was in a nursing home, and had a aide who would do the FaceTime with us, and my wife Karen was allowed to be with her mom as in the last couple of days of her life for part of the day in the nursing home. But I think while COVID was the on the death certificate, while her cause of death, she died of loneliness because of the isolation, because of the nursing home. They could not leave their rooms. And they, my mother-in-law had some dementia issues, but she would sit in a room like this and just watch other people, and she keep track of what was going on in her mind, and just being with other people, and she had no one else to see. Her roommate and her, the two ladies, both in their 90s, and both ladies would pass away in a short span of time. It's 2.5 months into COVID. And so that isolation was a very real thing for patients in the hospital who couldn't be with family. Staff dealing with that, and Sue talked about things that staff had to do to care for themselves. Isolation is a very real problem that we were dealing with.
isolation that the medical teams felt, I think, was palpable. They were very commonly understaffed, and there became, I think, a bond among the teams that was very important for their resilience. They had to rely on each other in order to get through every day. I saw that happening in our department too. If somebody couldn't make it in, there was never a doubt in my mind that somebody would be able to step up. And we all shared that responsibility. I would get a call at 10 o'clock saying, you know, the 11:30 person may have COVID. And I also would go in for the overnight shift at the last minute, and other people did the same thing. But one of the providential things that happened was that about a month before the pandemic, we had just started a new initiative to minister, in effect, to our staff. Our chaplains created a program called the Chi card, Chi meaning energy in balance, from the Eastern religious tradition. And we had a cart with hot water for tea and healthy snacks. And the idea was to go out to the staff to greet them and to offer them some hospitality. That became extremely important on many different levels during the pandemic, and it continues even now in an important way.
So Tom just let us know that chocolate and Rice Krispie treats are healthy snacks.
They're not just for breakfast anymore. The staff would be very reluctant to take breaks because the needs on the floor were so intense. And so we quickly found where the greatest intensity was, and we would go there even more often with the Chi card. And it was a stress reliever, and it brought a sense of acknowledgement of the sacrifice, I think, that the staff were making to know that they were seen. And sometimes it would be just a piece of chocolate, and sometimes it would be conversation about very weighty matters. But regardless of the type of interaction, it was very important. I know this because almost a year after one visit, a nurse came up to me and still makes me emotional. She said, "You don't know how important that visit was when you came with the Chi card." I didn't recognize it at the time, but she said that this was how she was able to not quit that day. And, you know, if we can do that without knowing it and find out later, that was just such an important understanding that I came to as a child.
I had just one more thought, kind of with this theme of the isolation and the lack of connection between people. So I have to confess to breaking the rules. But when we were in rooms with patients, we were supposed to keep that distance. We were protected often with that PPE. We were protected with the PPE. And it prevented me from doing what I normally would do if I was with a patient, and whether I was going to offer to pray for them and they accepted that, I might ask if I could take their hand, or if they're tearful and sharing part of their story, put a hand on their shoulder. Well, I wasn't supposed to do that. But there were times as we moved into that pandemic, which it was like, I need to connect with this person. Yes, I was protected. But I just chose to make that difference in that one-on-one visit. And I think that was the right decision for me to do. We weren't supposed to do that, but yet I was mindful, and it was trying to provide the best care that people needed at that time. But it was just another image that kind of came to mind as we were talking about that.
I think what I appreciate what Sue was just saying there. I had to approach dealing with COVID, not fearlessly, but not fearfully either. You respect the boundaries that these items gave, but you also recognize there are times when touch was needed, not to overdo that, but also to let that person know that they are not the disease. And but also when there's certain precautions. There was one room I was going to enter into in an ICU, and a doctor stopped me and said, "Don't go into it." It's not because they're recognizing there's a place. I respect the authority that the infection control is dealing with, but recognize, so not fearlessly, but not fearfully either. There was just a healthy understanding of what the disease is, but also what our role is and how we can best to it.
A very important resource that I discovered new in my position was the support from the Reading Hospital Foundation. They were keen to work together with the Department of Spiritual Care to provide assistance in whatever form to the staff. And we were able to bring a group of lecturers that before COVID we wouldn't have been able to bring in, because these were national folks who presented virtually, much like we are today. And we had a series of lectures on spirituality and resilience, which were provided to our medical teams and to anyone who had an interest in that area, who were employees of Tower Health. So we had 6 lectures across 2021 bi-monthly that were, I think, very helpful. And we also received another grant for 2022 to begin a program called Schwartz Rounds, which is for the entire hospital community at Reading. And on a monthly basis, a topic is chosen where there's a panel of hospital employees who talk about their particular experience regarding the topic, and then the moderator opens up the conversation to everybody in the auditorium, and it's a non-judgment zone, very confidential, where people can talk about how being in healthcare impacts them on a human level, and it provides a sense of unity that, again, is essential to being on a healthy path as a healthcare provider, to know that there is support from your team and your community in that difficult work that you do. So we're looking at another grant for the coming year to provide mindfulness-based stress reduction, and to roll that out first with the team that David talked about, the crisis intervention stress management team, because if you don't take care of the people who are taking care of the people who are injured, then you can have secondary trauma to those folks too, and it adds up and it has to go somewhere. So we're looking at providing more resources through the Reading Hospital Foundation, including a journaling program that's going to be provided to nurses. It's a research program that's going to be also written up and shared with the medical community. So I think there's some really good things that came out of COVID and some really horrible things.
We have shared extensively, and I'm just wondering whether there's any questions.
So in our audience on Zoom, the question came up quickly about isolation. They feel that you addressed that very thoroughly. There's a chaplain on Zoom who was in a skilled facility, and chaplain felt isolated and saw many deaths and did not have that big support. So this is good for her. My question I have is, will any of the crisis intervention things be available to the public or recording, or to other chaplains in the community who might not have the resources through their respective workplaces?
That's a interesting question. Most hospital environments provide things like employee assistance programs for their staff, if not a crisis intervention team. The other avenues that sometimes employees get support through is violence prevention committees and things like that. A conscious decision was made for the spirituality and resilience lectures to make that for tower employees. So that wasn't available beyond the hospital community and for its own staff. But there certainly are a lot of online programs for chaplains who don't have access to any of those resources, including through the National Institutes of Health and other areas. I mean, if anyone is looking for resources, please contact me at Reading Hospital, and I'd be happy to tune them into some helpful resources.
To date, with the times we've done the systems for people in the hospital, the community involvement has been restricted to those if they're an EMS worker or police or fire who have been involved with a particular case, and they have been invited to participate. But generally, it is, from our thing, it's been limited to the hospital, but or those who have been providing care in a particular setting for a particular incident.
That's old age.
Stellar work. Stellar work. It's impressive that you stayed and hung in there with direct patient visits. I don't know of any colleague of mine that I know in other hospitals around the area that manage that. I think I'll credit Reading Hospital for that as well, because they implemented that. I certainly know what it's like to carry unprocessed, stressful material, and have done so in some regards for years. What I'm curious about, what I think you haven't actually touched on yet, is, and maybe this is the beginning of that, but how do you propose to deal with process the personal, emotional, spiritual impact of this going forward.
Having a fairly robust team, around 12 members, plus or minus. We have a lot of camaraderie. There's a spirit of mutual support among the chaplains in our own department. As a director, I encourage people to have downtime and for them to reinvest in themselves personally during that downtime. We've had several retreats for our entire staff, but the process of preparing for the retreats is as important as a day away. So, for example, people have been provided with books that are pertinent to self-care and to working on our own spiritual lives, our own spiritual growth, in order to be effective in helping others with their spiritual needs. You have to tend to your own spirituality. So if you're not focusing on that continually and developing your own spiritual life, then I think then you would not be able to respond in the way that this question asks. But that is an ongoing issue. It's it's not that somebody has a calling or a title that is sufficient by itself to continue to be spiritually available to others and healthy in your own life. It requires constant tending.
Dave and I were fortunate to be supported, I think last fall, to attend an online seminar, several sessions that was focused on resilience for spiritual caregivers. So one thing that we did once we returned, or after that had been completed, we put together an interactive presentation that we shared with others in our department that kind of sort of started cracking that open, what you alluded to, Greg. That and one of the first things is to actually acknowledge I've been affected, I've been impacted by this, and from there you can move forward in how was I impacted, what am I going to do about it? And we talked a lot about what that spiritual resilience is, which is different for everyone. What is most important in helping people unpack and move forward. And we talked about how we could provide that content in that same format or a different format with other folks in the hospital and or maybe the wider community, but we it's kind of challenging to try to figure out how to work around the different schedules and all the just what's in a large institution like Reading Hospital and Tower Health of how we would do that, but it's something that maybe we can rethink about.
So I really appreciate your vulnerability and sharing your experience over the past 2.5+ years. As a fellow chaplain myself, who worked in a very different setting than your environment. I work with long-term care residents who were physically, mentally challenged, as well as in a rehab hospital and an LTAC. So we would get folks post-COVID still on vents and trachs, long-term, that will have life, the rest of their lives impacts from the effects of COVID. That's really tough work. the other settings, working with long-term care residents being isolated from March until August in their rooms. Eating with plastic forks and plastic knives on plastic paper plates. We were in an environment with red, yellow, and green on the doors, depending on what status they were. You know, the whole green light, red light, yellow, depending on what PPE you have to wear. Just resonating. I obviously need to process my experience too, but one of the things that I found hopeful and also supportive, if you remember, the national awareness on the work that chaplains were doing, because we were end of life, like we were one of the ones allowed to be in the rooms when people were taking their last breath. And, you know, newspapers and news media picked up on that. Like, we know the work we do as chaplains, but the rest of the country got to see, and we were, you know, amplified in those settings. And I just, you know, appreciate this so much this morning that you all have helped tell your story to the wider audience and the wider community about what it's been like. So thank you.
One last thing about that was getting this, but also one of the things that staff had to deal with frequently were people who were in denial of the extent of COVID. And sometimes within their own families or extended families of having to deal with, you know, it's like, and not, because they didn't see firsthand, because they couldn't go in and trying to help people understand the reality of what was going on.
Okay, quick. Intrigued about your Chi card. Because I still remember from 50 years ago in my internship, when the safety officer brought us peppermint candies right after rounds when we were, you know, overwhelmed. And he took those few minutes that we were digesting the peppermint candies to give us safety information. And I'm thinking that your Chi card is probably having the same kind of impact.
I think so. It's a mechanism that is permission giving to for the staff to take the encounter wherever they need it to go. One of the interesting things for me was I didn't always know everybody's name, and I would see the cart go out about to 1,500 visits a month, but I knew everyone's order. So, because you know, you don't always catch a name under the mask, and the badge might be hidden under the PPE, but I knew what they wanted, and they appreciated that. So there was camaraderie in that. Sometimes the mood on the units would change after the Chi card came. And I remember one nurse was on the phone as I rounded the corner with the Chi card, and she was talking to a family about the medical status of their family member, and her voice just lifted, and she completely changed how her mood was being expressed in that moment that she saw the Chi.
So what was on?
Well, the best thing, in my opinion, was Lindt chocolates. So
There you go. That's a nice way to end with chocolate. Thank you so much. Very helpful, most definitely, this presentation for now and for history. When we look back, there's a lot of things you kind of forget about until you listen to folks talk about it. So I'm very glad that you were here. You were helpful to our Zoom teams also, and your email address was placed on the Zoom. That won't show on YouTube. You won't be getting emails for in perpetuity. So, we definitely thank you. This is very important and impactful.